Welcome back to the online course of Victoria's MPs, and we're on the hematology, oncology, and the immunological systems and disorder. Today we're going to talk about iron deficiency anemia. Iron deficiency anemia is the most common anemia that you will encounter in your practice. So it is important we spend a little bit time on it. First, did you know that the only way the body gets rid of iron is via menstruation? So when we have a iron deficiency anemia, we first of all, iron deficiency anemia is a microcytic hypochromic anemia. So what does that mean? Is microcytic because when we do our iron levels, the MCV is going to be lower than 80. So it's a small cell anemia. It's hypochromic because it's going to be pale. So what are the common causes of iron deficiency anemia? Usually it's either through blood loss, as you can see on the picture. You're either losing blood somewhere. It could be GI bleed, it could be heavy bleeding, or impaired intake of iron, or either through poor intake, supplement-wise, or feeding, or even impaired absorption of iron. So in adults, for example, the most common cause of iron deficiency anemia is through blood loss. If it's someone that is still in that childbearing age, it could be heavy bleeding during menstruation. So you want to think about that. If it's a man or someone that is postmenopause, we want to make sure they're not losing blood through their GI tract. If it's a kid, in most cases, it might be through diet, poor intake of iron-rich diet. So what do we do about this? First, let's look at the signs and symptoms that you're going to encounter in the iron deficiency anemia. They're going to have dyspnea due to the low hemoglobin. They're going to have fatigue due to that low oxygen. They're going to be tired. They're going to feel weak. There'll be palpitations, tachycardia. They'll be pale, and don't roll out restless leg syndrome. That you can see also in someone with iron deficiency anemia. But when you think about the ones that all these symptoms, you can see it in other forms of anemia too. So what is more synonymous with IDA will be the ones I highlighted in red, which is your pica, your koilosenia, angular cheilitis, glossitis. When you get any of those in your exams, then you just think iron deficiency anemia. So what does this mean? Pica is when they give you this patient that is having cravings for non-nutritious, something that is not food. It might be a kid that is craving like clay, like sand, or someone that's craving ice chips. This is how they tend to bring that. So they pica. Then if it's koilosenia, what that means is the spoon-shaped nail. So a way of remembering, I just look and there's a coilo, it coils. So that's how I remember that. Spoon-shaped nails. Angular cheilitis is that crack you have at both angles of your mouth. Then glossitis is when you have that beefy tongue that is just glossy because they've lost all that papilla. So glossy, beefy tongue. So in terms of your lab levels, you're going to see a low hemoglobin, low hematocrit, low red blood cells, which makes it anemia. But then you're going to get your MCV will be less than 80, makes it microcytic. Your MCHC will be low, it will be hypochromic. Then you're going to get a low serum ferritin. From our previous videos, I mentioned that your ferritin is your storage. Your iron storage in the serum is your ferritin, while your transferrin is your transport in the serum, that transports your iron, and it's synonymous with your total iron binding capacity. You know that your ferritin and your TIBC or transferrin, they work inversely. So if your ferritin is high, your TIBC or transferrin will be low, vice versa. So in this situation, you're going to get a low serum ferritin, so you're going to get a high TIBC or high transferrin. Then you're going to see in your iron deficiency anemia your RDW, which just measures your cells, the difference, the variability of your cells will be high, because as your hemoglobin becomes lower and lower, you start making less smaller cells. So as you make smaller cells, the variability will start increasing. So your RDW will be low. Will be elevated. So what do we do to manage that? We want to give the patient iron supplement. We give them ferrous iron sulfate. We tell them to increase their food intake in iron-rich food. For example, your leafy vegetables, meat, raisins, iron-fortified cereals. We want to encourage them to take their supplements with orange juice, because it helps with the absorption of iron. We also want to teach them to avoid eating make sure that between taking the medication and actually eating, they give about 1 to 2 hours in between that. Because what happens is when they eat so close to taking their medication, the food is going to absorb the medication. So they're not getting they're going to lose the amount of absorption that they need. So it's going to, you can probably cut it like into half. So we want to tell them to make sure they take their iron within an hour or two before meals. If these patients are on antacid, they want to wait about 4 hours in between before they take their antacid. 4 hours between the medication and antacid, because otherwise it's going to just bind the medication, and they will be able to get the absorption. We also want to make sure we let the patient know that they might have dark stools, they might be constipated, so they want to increase their fiber intake. If possible, if it's needed, we might, as a provider, prescribe stool softener if needed. Also, as a provider, if we have a patient that is complaining of dark stools and we do guaiac and is guaiac negative, we want to find out if they are on iron supplements. Chances are they are on iron supplements. So this is for iron deficiency anemia. Then we're going to go to the next microcytic anemia, which is going to be your thalassemia.